As hepatobiliary pancreatic surgeries have evolved, so have we as anesthesiologists evolved to manage chronic liver disease patients, especially during transplant surgeries. Let's learn about this in our next session. Ratnakar is the President, ISA Telangana State, private practitioner at Karim Nagar, Telangana. President, ISA Telangana State, onto the dais. Dr. Mudiganti Ramakrishna Reddy, Professor of Anesthesiology, Honorary Secretary, ISA Telangana, Hyderabad. Chairpersons to introduce the speakers. The first topic for today is liver cirrhosis. Patient posted for tips, anesthetic considerations by Dr. Shyamsundar.
I'm pleased to introduce Dr. Shyamsundar. Dr. Shyamsundar P. is Additional Professor, Anesthesiology and Critical Care, Amrita Institute of Medical Sciences, Kochi, Kerala. He completed his MBBS in 1997 from Coimbatore Medical College and Diploma Anesthesia 2001, Coimbatore Medical College, and DNB 2003 from Amrita Institute of Medical Sciences. And his other qualifications, he is a Fellow of College of Critical Care Medicine by Critical Care Education Foundation, Mumbai. European Diploma in Intensive Care by European Society of Intensive Care Medicine 2014. His areas of interest: liver transplant anesthesia, difficult and prolonged weaning, advanced respiratory support, including ECMO. Over to you, sir.
Thank you, sirs. At the outset, I'd like to thank the organizers for having me here to share my thoughts on anesthetic concerns during TIPS procedure. Our institute, Amrita Institute of Medical Sciences, Cochin, is one of the leading centers doing liver transplant in the state of Kerala. We were the first to do and still the largest center in Kerala. Background for TIPS, as you all know, there's an increasing incidence of liver disease worldwide. And liver disease now accounts for almost 4% of all deaths in the world. That is, 1 in 25 deaths is due to liver disease. This is data from 2016. But at the same time, the estimated deaths due to liver disease in India is slightly lower at 2%. Even though this is lower, if you can see in the 2 million deaths annually due to liver disease, 1/5 is from India. It's a huge number. That is almost 4 lakh deaths per year due to liver disease in India. That's the burden of liver disease even in our country. 2/3 of liver-related deaths are in men, and most of the liver-related deaths are due to either cirrhosis or hepatitis C. The liver diseases, as you all know, is mainly due to ethanol, but non-alcoholic fatty liver disease, which is upcoming, is the increasing incidence is being noted. Viral hepatitis still remains the leading cause of liver disease, especially in the third world, like Africa, Central and West Asia, and South Asia and all. Coming to portal hypertension per se, TIPS is done usually for portal hypertension. So I'll not be concentrating on cirrhosis. We'll just look at a little bit of portal hypertension. As you all know, liver, the blood flow is it's unique. Of the 25% of cardiac output goes to the liver, which is 1/4. It has 2 supplies, as we all know, one through the hepatic artery, which gives the oxygenated blood, but it also has a nutrient-rich blood coming through the portal vein. And the venous drainage is through the hepatic vein into the IVC. Portal hypertension, the reason for that is the trigger is an increased resistance to portal venous flow, as we all know. That's the main reason in any vascular bed. When there is an increased resistance to flow, you will have hypertension in that bed. So portal hypertension is the same. The main reason for this being a structural disruption that you see in cirrhosis, which is the leading cause of portal hypertension. Almost 90% of causes, the reasons for portal hypertension is cirrhosis. You can also have an acute, obstruction in sepsis, and sometimes if there is when there's people go on a binge drinking, high alcohol, that can cause an acute but usually portal hypertension is a chronic phenomenon. And you all know that portal hypertension, the causes are into three: pre-hepatic, intrahepatic, and post-hepatic. Intrahepatic is the main one, cirrhosis, either ethanolic or non-alcoholic fatty liver disease. And post-hepatic also you do get when there is hepatic vein obstruction, like in Budd-Chiari. How do you diagnose portal hypertension? Usually it's diagnosed clinically with the background of cirrhosis, especially with complications of portal hypertension when they develop, like the patient has ascites, variceal bleeding, splenomegaly, or thrombocytopenia due to hypersplenism. But the confirmation, if you want to confirm portal hypertension, you'll have to do a angio and look at hepatic venous pressure gradient. The normal is up to 4. And anything above 6, you have portal hypertension. And the complications due to portal hypertension usually occur when the hepatic venous pressure gradient goes more than 10. So coming to TIPS, the procedure that we are looking at, if you can see, it's a shunt, transjugular, intrahepatic, porta systemic shunt. So this is the portal vein over here, which is formed from the splenic vein and the superior mesenteric vein. This is the hepatic vein. So we connect we put in a shunt between the portal system and the systemic system so that the shunt happens so that the portal venous pressure can be reduced. So what are the indications? The two main indications for doing TIPS usually in cirrhosis is either a resistant ascites or for control of variceal bleeding, not an acute bleed. If the patient has a recurrent bleeding, that's when we go and do a TIPS, but the most important reason would be resistant ascites. So there are proven benefits, including survival benefits, have been shown if you do TIPS for these two reasons. There are some limited evidence for doing TIPS in various other scenarios like this, Budd-Chiari and all those things. But the main reasons would be resistant ascites and control of variceal bleeding. So in this picture, I'm not sure if you can see it well. That's the shunt in place, which I showed in the picture there, the animated picture, that the shunt that you see there, the white one, you can see that the shunt has been placed between the portal vein down there and the hepatic vein up there. Do we have contraindications? Absolutely. The most important contraindication, would be is heart failure. So assessment of the cardiac function is very important. I'll be coming to the assessment a little later. So heart failure is an absolute contraindication. Severe tricuspid regurgitation, severe pulmonary hypertension, especially with a mean pulmonary artery of more than 45 millimeters of mercury. And for technical reasons, if there is multiple liver cysts or biliary obstruction. And finally, if sepsis is there, we wouldn't be doing it at that point of time. And there are some few other relative contraindications as well. So the procedure, the right IJV is usually cannulated, and then they go into the hepatic vein. Usually they go to the right hepatic vein. They do measure the hepatic venous pressure gradient, which is the difference between the free hepatic venous pressure and the wedged hepatic venous pressure. And then after measuring that, it's important to measure at this point of time because we want to see if the pressure has dropped after the shunt is placed. So they measure the pressure, and then they create a tract through the guide wire between the hepatic vein and the portal vein. The portal vein is approached directly just before the division. That's very important because the hepatic vein, where they are doing this it's the intrahepatic part. The most important thing regarding the portal vein is also you should get into the intrahepatic part of the portal vein. If the communication is created in the extrahepatic part of the portal vein, you're going to have torrential bleeding, which could be uncontrollable, especially with the coagulopathic background that they come from. And finally, this tract is then dilated with a balloon. Dilatation is done, and a PTFE nitinol stent is placed. It's a partially covered stent. The stent in the intrahepatic portion is covered, and the extrahepatic portion is usually not covered. So coming to the pre-anesthetic workup, like I said, what are the considerations? The most important thing is to look for the cardiac status, also respiratory, coagulopathy, renal, and baseline cognition. We'll just quickly look at all these things. What are the challenges that we face, especially during or after? There's a tremendous increase in the cardiac output after the TIPS is inserted as the pooled venous blood now returns into the systemic circulation via the shunt. That's one of the concerns. The other thing is these patients tend to have ascites. That's the main reason they are undergoing the TIPS. So they will have hydrothorax as well. So the FRC is always reduced. So we need to take that into consideration. They have thrombocytopenia. They have coagulopathy. So they are at a increased risk of bleeding. And we are puncturing 2 big vessels. So you can understand the amount of risk that is involved over there. Renal status is always a concern in liver patients. not only because they are liver patient, but because we're going to give a huge contrast load to them during the procedure. And encephalopathy, as we all know, is basically itself is because of the portosystemic shunts. Now, that is what we are doing here. So if they are not already in encephalopathy, they will develop encephalopathy in the post-procedure period. So, like I said, the most important assessment is that of the heart status. It's very important to look at heart failure. We need to do a transthoracic echo to look at the LV function, and we also look at pulmonary hypertension. We need to grade it. Like as mentioned earlier, severe pulmonary hypertension is an absolute contraindication. You have to assess the degree of tricuspid regurgitation that is there. And it's also important to have a basic ECG before you send them over to the cardiology, because there is a pre-existing LBBB. Now, we are going through the right atrium. You don't want an RBBB setting in and then it leads on to a complete heart block. So an LBBB pre-existing would be a relative contraindication, not that it's an absolute contraindication. If someone had, you don't get this sort of an X-ray in a chronic liver disease patient, but if this would be an X-ray of a severe pulmonary hypertension patient. Coming to the respiratory assessment, like I mentioned, there's a decreased FRC due to ascites, hydrothorax, and all that. But these patients tend to have significant effusion, which causes dyspnea, desaturation for them. So in our institute, most often what we do is we put in a pleural drain on the day of procedure, and the drain is kept there so that you can have a continual removal. If there is significant ascites, that we tend to tap it the day prior with albumin. As you all know, we supplement albumin during the procedure, and this pleural drain is continuously kept over there. And this is an X-ray of a patient who had a pleural left-sided hydrothorax. Usually we have right-sided hydrothorax, and post the tips, this is how the X-ray of that patient improved. Coagulopathy, we need to optimize. Thrombocytopenia is frequent. There's an elevated prothrombin time. Anemia is not uncommon as well. And what are the triggers? 50,000 more platelet count is what is preferred. Sometimes we will not be able to achieve, but then we tend to transfuse platelets, single donor platelets on the day or prior to surgery. INR, if we can keep it, less than 1.5, if that is possible, but sometimes it's not achievable. Transfusion trigger for blood, we keep it very low. If it's less than 7, we could transfuse, otherwise we could wait. And we could do a TEG to assess the risk of bleeding as well in these patients. Risk of AKI is of paramount importance because of the underlying vasodilated state. They could have some degree of hepatorenal syndrome, and most importantly, the contrast load that we're going to give during the tips. So to prevent this, what we can do is we can give volume expansion. We tend to use quite a bit of albumin during the procedure, so at least 1 or 2 pints of bottles of albumin we would give. That helps us in maintaining the intravolume status. Maintaining hemodynamics, MAP, we always tend to talk about 60, 65. Should we go for a higher MAP here, 70, 75? Maybe 80 would be a good target here to prevent renal failure, AKI post-procedure. And by correcting hyponatremia, that's also very important. And you could give an acetylcysteine, not that it's found to be useful, but it's generally given for a 48-hour period. And the hepatorenal syndrome, you're all aware of the new terminology. HRS1 is now HRS AKI, and HRS2 is HRS non-AKI. So just put it up there. Finally, cerebral evaluation. You have an increased risk of hepatic encephalopathy because already they could have an underlying encephalopathy, and we are creating a big shunt. So there's the reported incidence is 20%, going almost 35-40% incidences of encephalopathy has been reported. It's important to look at the last intake of alcohol from the patient side, because that could be another risk factor. Electrolyte imbalance, hypokalemia, hyponatremia can exacerbate the encephalopathy, so you would want to monitor and correct them. And sedatives need to be chosen appropriately. Benzodiazepines, better to avoid. Opioids, be very cautious with them as well. This is just grading of hepatic encephalopathy. So coming to the anesthetic technique per se, we could consider doing it under conscious sedation using short-acting agents, propofol, remifentanil, but it's still not available. But when you do it under conscious sedation, what about the patient comfort? Can they lie down in a supine position? They always they have some sort of degree of respiratory compromise. The airway is definitely compromised. Ventilation could be affected. They could get agitated if they have some degree of encephalopathy, which would hinder the procedure per se. And you don't want them jumping up when they're cannulating big vessels like that. And especially during balloon dilatation in patients who, when they're done under conscious sedation, they seem to experience significant pain during that point of time. So this is how the suit will look like, the radiology suit. So I'm not going into the considerations of non-operating room anesthesia here because of want of time, but you need to see that this is the patient here, this is the trolley there, and our anesthesia machine has to be kept on the left side somewhere down. We keep it somewhere in the middle, or it comes to the foot end. So you're mostly on the left side. The anesthetist, the main interventional radiologist, is going to be at the head end, the one doing the interjugular puncture. You have another radiographer who helps the main radiologist. The second radiologist does the ultrasound, because while puncturing the portal vein, they do it under ultrasound guidance, though the other things are fluoro guided. Puncturing of the portal vein is done ultrasound guided. So you have another radiologist over here. Then you have the radiographer, the scrub nurse. So the whole place is going to be congested, and you have the big C-arm coming up here. So these things need to be taken into consideration. So general anesthesia is what we generally go with. IV access, I don't need to stress the importance of that. Central line, they are going to choose the right internal jugular vein, so you don't have that. So you'll need to look into where you can place a central line if you need that. We don't always place central line. If we have good access, do peripheral lines, we do that. Monitoring standard, but it's important, like non-operating room, sometimes we don't tend to have ETCO2, but it's good to have ETCO2 here as well. We always monitor arterial blood pressure and most importantly urine output. Intubation is rapid sequence. I'm not going to the drugs per se. Maintenance, we tend to use sevoflurane. Fluids, balanced crystalloids, like I said, plus albumin and products as required. Hemodynamics can be a concern, so noradrenaline is always kept ready. Post-procedure ICU stabilization, mainly to look for hemodynamic monitoring because there could be bleeding. But since this is an intrahepatic thing, the bleeding is usually contained. There's a tamponade effect. So that's why it's important to hit the hepatic vein and the portal vein in the intrahepatic portion, so the bleeding is not significant. But the portal vein puncture sometimes can happen extrahepatic, then it's going to be a big bleeding over there. We do tend to extubate them on table, but if needed, sometimes they might need a non-invasive respiratory support in the post-op. Sepsis is a big concern, so broad spectrum antibiotics are given at the beginning. And most importantly, look for hepatic encephalopathy, which will usually subside with routine measures, but if need, sometimes they have to go for a shunt reduction or a shunt occlusion, temporarily if hepatic encephalopathy is severe. But those are usually not required. Watch for renal parameters. And there's a delayed hemolytic anemia happening 7 to 14 days because of the hemolysis that happens through the shunt. I'll conclude with a couple of slides. So this, before the shunt is placed, I want you to notice here, like you can see the liver filling up totally over there. And on the right one, this is after the shunt. If you can see, the blood is going off through the shunt, so it doesn't fill up like that much. So that is evidence that the shunt is in situ and working well. Thank you.
So, thank you, Dr. Shyamsundar. It was a nice lecture. Now